Welcome to RhAPPcast, the official podcast of rheumatology advanced practice providers. I'm your host, Amanda Mixon, the current president of RhAPP. In today's episode, Unpacking the Differences, IL-23 Inhibitors in Focus, we're diving into the evolving landscape of the IL-23 inhibitors and what differentiates them in our clinical practice. From mechanism of action to patient selection and safety considerations, we'll explore how these agents fit into the broader treatment paradigm for rheumatic disease. Joining me is Audrey Gibson, an amazing clinician and RhAPP faculty member who brings valuable insight and practical experience to this important conversation. Audrey, since it's been a little bit since our last appearance together on the podcast, would you mind giving our listeners a quick introduction?
Yes. Well, first off, thanks for having me. But my name's Audrey Gibson. I'm a physician assistant. I have been practicing in rheumatology private practice for almost 20 years now, which is crazy to me. And my practice is located in Gainesville, Georgia, which is about 45 minutes northeast of Atlanta.
Awesome. Well, again, it's so amazing to have you here. Most of you probably have seen Audrey. Hopefully you've come to our conference. Audrey, we always choose to do year-end review. One of the most challenging topics, because certainly you can never just repeat the slide deck from last year. But I can't think of somebody better, which is why you will continue to do it until you tell us otherwise. But whether you're, integrating IL-23 inhibitors into your practice, or if you just want to stay current on the emerging data, this discussion is designed specifically to support your decision-making and deepen your understanding. I know I, for one, I love this class of medications from its safety to its efficacy. So I'm really excited to have this conversation with you. I'm going to start off with just some questions and then we can kind of work our way through it. So to start off, can you just give us a little refresher on the IL-23 pathway and its relevance in rheumatic disease?
Yeah, so we'll start off talking about the pathway of IL-23 here, and I'm by no means an expert. There's many more eloquent speakers than I to talk to this, but we know that, IL-23, it's a pro-inflammatory cytokine. It's primarily produced by the dendritic cells and macrophages in response to pathogens or, some tissue damage, something that the body comes in contact with. But once it's released, IL-23, it acts on memory T cells, which particularly promote the expansion and kind of survival of Th17 cells. And then these cells, in turn, produce a lot of our cytokines that we're familiar with, IL-17A, IL-17F, that really drive that chronic inflammation, neutrophil recruitment, and ultimately cause tissue damage, which we know are key features in our autoimmune and inflammatory diseases. And really, in our PSA patients, IL-23 plays a really central role in that IL-23, IL-17 axis. It fuels skin and joint inflammation. And by inhibiting that, we can reduce both psoriatic skin lesions, but also joint symptoms too. So IL-23 really plays a huge role in that spectrum of psoriatic disease.
I think you actually made that really easy for me to understand. So, which, it's funny because I've sometimes, had to do the immunology lecture at RhAPP, which, is always such a challenge for me too. But basically you block this one cytokine that we know is very central to the, spondyloarthropathies. And by doing that, you also are working downstream to block other inflammatory cytokines. So, you're not just inhibiting this one thing. You're really kind of reducing inflammation, from a holistic kind of perspective is kind of what I hear you saying, at least from a psoriatic disease. So, on that same token, you mentioned psoriatic arthritis. Can you walk me through the current IL-23 inhibitors that are approved in rheumatology and what they're all indicated for?
Sure. So in the rheumatology space, we really have two IL-23s that are indicated for psoriatic arthritis. So we have guselkumab, which is Tremfya. It's indicated for psoriatic arthritis. It's also indicated for moderate to severe plaque psoriasis. It also has indications for Crohn's and ulcerative colitis, but specifically for us in that PSA space. The other IL-23 is risankizumab or Skyrizi. It also has an indication for psoriatic arthritis. as well as moderate to severe plaque psoriasis. In addition, it also has an indication for Crohn's and ulcerative colitis as well. But those are the two really in our rheumatology space that we are using right now.
Well, and again, you and I both have been practicing for a similar amount of time. And, I always, say this on the podcast, but, when we first started, we just didn't have a lot. And so our options were limited, which was unfortunate if people, didn't tolerate something or it wasn't effective. But now people that are coming into the space, they have all these options. So what factors do you specifically use when you're trying to make this decision of should I use an IL-23 over perhaps some of our other agents?
Yeah, I think that's a great question because, again, I've been practicing for a really, really long time, and it's always great to have options for our patients. But sometimes it makes it difficult for us as clinicians to say, okay, which path, should we go for this particular patient? And I think there's a couple key factors that really kind of help guide our decision making. First and foremost, I really try to look at the patient as a whole. What domains are they presenting with? Which specific domain is the most predominant, or the most active at that time? Whether it's a skin predominant psoriatic disease, or is it joint? But of course, we know that patients can present with enthesitis, dactylitis, nail disease, scalp involvement, and patients can also have axial disease too. So that's something that we have to really take into consideration and try to really treat and cover as many of those domains as we possibly can. One of the other, I think, really, really important things when we're trying to pick the best choice for a patient is also looking at some of those other maybe comorbidities, right, that patients present with. Do they have inflammatory bowel disease, right? Is that something we want to make sure that we're picking a treatment that can perhaps cover it, but we definitely don't want to exacerbate, that patient's underlying IBD. Do they have a history of recurrent infections? This is a big topic and a big concern for a lot of our patients. So trying to pick a therapy that's going to have less risk for patients, infection-wise, can be really, really important. Sometimes too, just sitting down and talking to patients about really what's important for them in their treatment journey. Some patients, it's as easy as saying they want less injections, or maybe they're needle phobic. And that's something that you have to consider when picking a therapy. So you kind of take all of those factors into consideration, and then you try to pick the drug that's going to work best for that patient.
Well, it really is. It's kind of this whole domain-based approach, right? Which is what I really try to do in all of my psoriatic patients. And you kind of alluded to this, but specific to the IL-23s, is there, a particular patient that you would say, okay, I think this is the correct one for an IL-23? You kind of alluded to it with the history of IBD. Is there anything else that other comorbidities that make you say, I think this is probably the best treatment for that patient?
But definitely think, if patients have really predominant psoriasis, a lot of skin disease, we know that the IL-23s work great as a class for skin. And so really, if I have a patient that has a lot of skin involvement, I'm thinking, an IL-23 kind of right off the bat. We also know that they have really great data for joint. So that's something that, if they present with skin and joint, that you're going to be covered both ways there. There's also great data, like I said earlier, in that enthesitis and dactylitis patient, and it's something where, you want to feel confident in that choice. And so that's one of the good things about the 23 is you have data to back that up, that you can see that efficacy. And then not only that, but you also have really, really fantastic durability in that class of drug, which, I tell patients all the time, there's nothing more disheartening to me as a clinician to get a patient under really, low disease activity or even into remission on a drug therapy, and then start to see them back. And you can see that that drug is kind of waning off. It's either not working as well, or they're having breakthrough skin lesions, or this joint is not as well controlled. And, then you're kind of back at square one. So picking a drug from the beginning, right, where you have that durability and you can feel confident that they're going to be able to stay on that drug for a long period of time. That's one of the things that I think about when picking, a drug for that class of patient.
Yeah, I feel totally the exact same way. I really love this, idea of durability. And I think it's important for everyone to remember that the first biologic is usually going to be the best for the patient, right? And part of that is because they're earlier in their disease, et cetera. But I also agree with you. I have patients, it's actually been pretty rare for me personally that I've had to take a patient off of their IL-23. People seem to do well with them, and again, I don't tend to see it, wane off like you mentioned. The other factor that I sometimes consider, I'm interested to hear your take on this. Obviously, biosimilars are here. They're not going anywhere. We all are using them. It's a day-to-day basis that I have to change somebody from one biosimilar to the next biosimilar to the next one to the next one. I think something that I actually like about these is there are no biosimilars yet. And so I know that, if I want to give them either, which IL-23, I know that they're going to get that medication that I'm prescribing.
Yes.
Do you consider that too?
So it's really interesting, I think, especially in the last year. Absolutely. I think last year obviously we saw the emergence of biosimilars, but it wasn't really integrated into our day-to-day clinical practice as much. So, we might have a patient here or there, they were being switched to biosimilar, but it wasn't as common as I'm seeing now. And not only that, I'm seeing a lot more where patients are just having to switch multiple times in a year from different biosimilars. And it's not, at least I haven't noticed so much that the biosimilars are not working, but it's really more that interruption in patients' therapy and patients' care. And so, they're having to get new prior authorizations, find out where they're going to get it from, the copay cards or the patient assistance. And so there's that lack of therapy in between where they're off their medicine, their skin is flaring, and, you're just seeing this increase of disease activity because you're having to constantly come up with an option. And I think that is one of the reasons I feel the same way, that I'm more using those 23 mores, because I know I'm not having to switch. I'm not going to have to switch to a biosimilar or in 6 months come up with another option that their insurance is now the new preferred drug. And I think that's better ultimately for patient care. And long-term outcomes.
I totally agree. And not to mention the bogging down of the staff that have to continue to do these PAs over and over. I mean, it's obviously we could have an entire podcast about that. Yeah. But yeah, so so obviously we're on the same page. Now, we obviously have two that you already mentioned, and both great drugs. So it's really also dependent on the patient, et cetera. But is there any, when you look at the efficacy profiles comparing the IL-23s, are there data endpoints that you find most compelling?
Yeah, I think we look at a lot of things, especially, as rheumatologists, we're looking at the whole spectrum, right? Obviously we're looking at joint endpoints, right? So ACR 20, 50, 70. We're looking at PASI scores, how much clearance are those patients, getting. I think one of the things that's come to light more recently is, the potential for structural inhibition. That inhibition of structural damage we have some new data about that, which we can talk about that a little bit at the end of the podcast. But I think, really joint, skin efficacy, those things are things that we look at. And then, of course, long-term safety, right? We want to make sure that a drug is going to work, but we also want to make sure that it's going to be safe for patients to take.
Well, and from that perspective, I mean, that safety thing is one of those other ones that I really think kind of separates, in my opinion, this class of therapies against some of the other ones. You look at the data, and of course, I tell everybody it suppresses your immune system, so we have to be cognizant of that. But, you really don't see a lot in terms of that issue with this particular class. So I don't know. It always just makes me feel more confident, especially those people that do have those recurrent infections that, I think this is probably one of your safest options, right?
Yeah, I totally agree. I think, that low risk of serious infection, they didn't see any increased risk for malignancies, or MACE events, which is a hot topic right now. And of course, a lot of our patients are, they're at higher risk for cardiovascular events. So that, of course, is a really big concern. No risk of obviously exacerbation of inflammatory bowel disease, which is also really, really important. Just even from a standpoint of they don't require any routine lab monitoring. And for some of my patients, even that in and of itself can be a big deterrent when choosing a drug. They don't want to come for labs. So the fact that you don't have to do that routine lab monitoring with this class of drug can be a really positive thing for patients. And like you said, it just gives you a sense of comfort when prescribing them for patients, given that overall good safety profile.
Absolutely. I totally agree. And I think, the next thing we really kind of need to touch on is expectations, right? So, you're starting a patient on a therapy, and of course they want to take their first injection and, tomorrow go run a marathon, and I think part of that is just because how long did they wait to get in with us? How long had they been suffering before they even got the referral to see us? And so a lot of times these patients have been suffering for quite some time. And so, of course, when they're committing themselves to a biologic, which I think sometimes can feel overwhelming, scary, etc., they want to feel like, okay, first shot and I am cured, And so what are you telling patients, particularly to this class of therapies? Because I think it's important that we set those correct expectations to your patients.
Yeah, I think one important thing too is really to kind of evaluate where that patient is coming in their journey, like where they're coming in. If they have never been on any biologic therapy before, they don't have anything to compare that to, or like a bar where they're setting that standard. But I think setting those expectations up front is so vital and so important. I think it creates trust between us as providers and the patient. I think it improves adherence for patients. I can tell you hundreds of stories, and I'm sure you can too, where, you see patients and they say, oh, well, drug did not work. And I said, well, how long did you take it? And they said, oh, I just took one dose and it didn't work, so I discontinued it. And I was like, no, it's not that it didn't work. We just didn't give it enough time, right? So that adherence is really, really important, and emphasizing really long-term goals for patients. I always tell patients, this is a marathon. It's not a sprint, right? But if they know what to look for and kind of set some of those timelines up front, they can say, okay, I can see that it's working. I can see that it's doing what it's supposed to be doing. And they're more likely to stay with that therapy. So, especially with the IL-23s, I think that's important because typically, and at least in my clinical experience, you typically will see improvement in the skin first. You can see that early, but I usually will tell patients around 8 weeks, you should really start to see good clearance in the skin response, but it may take 16 weeks, right, for it to get fully into the system. In my experience, as far as joint response goes, I do think the joint does lag just a little bit in this particular class of drug. So sometimes, it may take, 10, 12 weeks, to start really seeing that improvement in the joint that you want. But it's one of those things where, like I said, if you can see that improvement in the skin, you can tell that the medicine is starting to work, and then you can start to see the joint improve. And then patients are like, yes, okay, this is what she told me. This is what she said is going to happen. And this is kind of the pattern that we're following. And then for some domains, like for nail involvement, right, you're talking 6 months at least before you really start to see that improvement. So I think that's really, really important for patients to have like really great outcomes.
Absolutely. I do the same thing. I basically kind of set the tone that I'm not expecting, it's wonderful when people come back after, 6 weeks and they're, magically improved. And of course we see that too, but I tell patients the same thing, like setting the tone that, so for this class, I really would not for me personally, consider switching for 6 months. Like if, unless there was absolutely nothing, which I haven't really seen, but, I suppose there's always going to be that patient that just doesn't respond to anything. Of course, if they didn't respond at all, I'd be like, do I have the right diagnosis? Am I missing something else? But yeah, so I think setting those expectations, so again, what I'm hearing you say is, again, this these are durable, therapies. We need to set the expectation with patients that it could take a little bit longer. Their skin's probably going to respond first, and followed by their joints. It's lovely when both happen at the same time, and that these are really safe options. And, I think that's, so important, all of those things, and really making sure that we're treating the domains we're up against. Some people do have concomitant IBD, even like microscopic. And so it is like not uncommon that you put a patient on a drug that also has IBD approval. And even though they don't have a diagnosis of IBD, they say, my GI symptoms are so much better, so it's kind of like, well, I believe that, sometimes they're that kind of microscopic or just hasn't been come to full, ulcerative colitis or Crohn's.
100%.
I have one last question for you. So are there any emerging data or ongoing trials that you're watching that could potentially impact how we think about IL-23 inhibitors in the future?
Yeah, so that's a great question. And there's several things, there's one that was recently presented at EULAR. We'll talk about that one. And then there's another upcoming trial too, which I think it's going to be really important in the space of psoriatic arthritis and psoriatic disease. So the first one, there was the APEX study that was presented in EULAR this year. That's with guselkumab. It's a phase 3B. That looked at basically radiographic inhibition. And what they did find at week 24, they used a modified Van der Heide sharp score, that they did see statistical improvement with radiographic progression in the guselkumab arm versus the placebo arm. So, I think sometimes we don't always think about radiographic, inhibition or progression, but I think it's so important and vital to our patients, because, one, we're trying to preserve that joint as much as we can. And then two, we know that structural damage, it correlates with disability. And so if we have that data to support that inhibition, right, of structural damage, that's what we want to do. We want to make sure that we're preserving the joint space, and, ultimately, keeping those patients working and hopefully decreasing that disability rate.
I totally agree.
Well, and the second one that hasn't been published yet, but it is kind of ongoing, is going to be the STAR trial. And that's with guselkumab as well. And it's in axial PSA. And I think this is actually really interesting study because I think it's becoming more and more clear that ankylosing spondylitis patients are different from PSA patients with axial spine involvement. And so, traditionally, the IL-23s really didn't show a lot of improvement in that ANK-SPON patient. So this specific trial, it's a phase 4. It's looking at biologic naive PSA patients who have MRI confirmed axial inflammation of the spine and or SI joint. And it's looking to see if they have improvement in their BASDIs. So guselkumab and those axial PSA patients. And I think this is going to be really, really interesting and hopefully really, really helpful and beneficial for us and our patients when that data becomes available.
And hopefully it will work, which I've seen in my clinical practice, but it'll be interesting and interesting, to see how it actually, plays out in a clinical trial. Thank you so much, Audrey. You're always just so lovely to talk to, and I love how real world you are. And that's, I think, how APPs shine, right? Like we really try to think about it in a bigger picture of like, how is this going to impact my patient? And I just think do such a wonderful job with that, which is again why if you haven't yet registered for the RhAPP annual conference, come and see Audrey because she'll be doing our year in review. So with that wraps up our episode of RhAPPcast. Again, a big thank you to Audrey for sharing her insights on IL-23 inhibitors and really helping us unpack the differences between this class and other, therapies that we might consider. If you enjoyed today's conversation, of course, please subscribe to RhAPPcast so you never miss an episode. I'm always just so blown away that people still listen. It's awesome that so many people and more people are listening. I think about when I first started as the host, and I don't know that I'd want to watch those episodes or listen to them, but come a long way as a podcast host. But you can obviously also, but really, it's because I have really, really good people to talk to. So that actually is why it makes, I think me look better as a podcast host. It's really just all the people that I'm interviewing. But if you enjoyed today's conversation, be sure to subscribe to RhAPPcast so you never miss an episode. You can also explore more rheumatology-focused education on RhAPP ACE 2.0 app, which is available for download, and stay connected, obviously, at rhap.org, where all digital education is housed in the content room. Thanks for tuning in, and as always, thank you for everything you do for your patients in rheumatology.